भी सोच रही हूँ जाऊं ना जाऊं जाऊं ना जाऊं जाऊं ना जाऊं। हम्म।
They're not receiving the call. I'm just.
Okay, then I think we can start, Asmita. Can you thank you, Dr. Deepa, for joining us today. And thank you all attendees for sparing your valuable time and tuning in to listen to Dr. Deepa Dash. Dr. Dash is an assistant professor and clinical researcher at the University of Western Ontario, Canada. She has finished her movement disorders from the University of Ottawa, and she is interested in clinical research, including population-based research in Parkinson's disease, patient-oriented research in movement disorders, and she has several funded projects from and currently doing a lot of good research work in association with our International Movement Disorders Society as well. So I think without much further ado, we'll like to ask Dr. Deepa to share her views on special considerations in treating Parkinson's disease in the geriatric population.
Thank you, Ila. I'm gonna share my slide and let me know if you can see it. Can you see it?
Yes, perfectly.
Okay. Good evening, everyone. So I'm going to talk about, and this presentation may have a little bit of a spectrum. So there could be some things which are very, very like a beginner's thing, and there could be some little bit more complex concepts. So I'm going to cover basically a very case-based management of patients who have Parkinson's disease, but with the focus on geriatric population, correct? So we all see Parkinson's patients in our practice as a general neurologist, as a movement disorder specialist, but there are some things that have to be kept in consideration, especially if we see somebody who's more than 70 years of age or like an older geriatric in the geriatric group of population. So I did so my background, which Ela didn't say mentioned, is that I worked in India for many years and actually moved in Canada in 2019. So I do understand how things work there. And although we see a lot of young patients, but we also see these patients who are in the geriatric population. I was a faculty in AIMS Delhi from 2011, 2019. I did my DM there. I did all my residency, everything, medicine residency and neurology residency from Delhi. So let's start. Oh, it's not moving. Okay, no, okay. So first question is, why do we need older patients to have a different approach? Why is it required that we have to have some information to manage the older population compared to somebody who's young? The phenotype that we see in older patient is different. They usually have a faster progression. They have a more higher rate of dementia rates. They have more axial symptoms, and they also have fewer dyskinesias, which is opposite of what we see in younger patients. They also have more cognitive, autonomic, and axial symptoms. So the burden of non-motor symptoms is much, much higher than what you see in a younger population, which is not levodopa responsive and not responsive to other dopaminergic therapy. So it becomes a little bit more complex to manage these symptoms. Why does this happen is mostly because we all know that Parkinson's disease is because of loss of dopaminergic neurons, but it causes more impact and both motor and non-motor impacts because the loss of compensatory brain mechanism. This has been seen by a PET study done in 205 patients. Additionally, There are these patients, especially in the older subgroup, have more comorbidities. They usually have diabetes, hypertension. They usually are on multiple medications. So definitely requires more. You have to really screen the medications. They also are likely to get more side effects from the dopaminergic medication compared to a younger population. So the tolerance is low. Their quality of life mostly is driven by non-motor symptoms. And of course, we know when we see patients in our outpatient clinics in the hospital, we really don't get time to go through all the non-motor symptoms because there's a big checklist. But most of the times, we usually focus on the motor symptoms and the pharmacological treatment of that. But the non-motor symptoms, and there's lots of studies to show that they usually drive the disability that we see in geriatric population. To add to that, these patients are more frail. A fall in them can lead to a life-changing situation compared to a young person who can deal better and cope better with that. They also are struggling with cognitive issues. So if you give them a complex regimen of dopaminergic medication, they have difficulty managing that. And the last but not the least is that we have most of the studies exclude this group of population. So usually most of the studies would say less than 80 years of age. So people who are in the above 80 group, we don't have enough evidence to understand what works and what doesn't work for them and what is their adverse effect profile and efficacy of medication that usually works for people who are younger. Now I'm gonna follow the whole presentation is going to be a case-based thing, and there'll be one person. This is kind of hypothetical patient who let's start with the first step. So this is Mr. A. He's a 70-year-old. He's a retired engineer. He presents with a 9-month history of right hand resting tremor. There's also change in his walking. He's shuffling. He doesn't pick his feet very well. He's slow in doing his activities. He has difficulty in doing fine motor tasks. His handwriting has become smaller. His wife notices that he rarely blinks. His affect has gone down. His facial expression has gone down. He also has past comorbidities in the form of hypertension and type 2 diabetes. He's on amlodipine, metformin, aspirin, tamsulosin. Sorry, there's a typo there. Examination, there is cogwheel rigidity, bilateral upper limbs, right more than the left, bradykinesia, asymmetric resting tremor, 4 to 6 third. You do the MMSE is 27 out of 30. Now, you also do the blood pressure, and I would suggest every patient that you see with a possible differential of Parkinson's to do a blood pressure sitting and supine and standing, or at least sitting and standing in the clinic. So this patient did have a drop from 128/78 supine to 108/70 standing. Usually, we also do MDS-UPDRS part 3, and the score was 32. Now, Parkinson's disease, in the context of how you diagnose it as a clinical diagnosis, we usually follow the UK Brain Bank criteria. There is the MDS 2015 diagnostic criteria. If you go through the story of this patient, it looks like it probably meets the criteria. There are no red flags for atypical features, although I didn't say all those longs. No, it doesn't have those red flags. So he has bradykinesia, he has muscular rigidity, he has a resting tremor, he has asymmetric onset. So the next step usually would probably do a CT head, but we also start a dopaminergic medication. Now, what would be the drug of choice? And this may not be very different from a young patient, but an older patient. But what drug should be started in a patient who's 74 years old? So there is evidence to back that patients who have in the older age group, levodopa has superior motor benefit versus dopamine agonist. Levodopa is more likely to cause dyskinesia, and that is a concern, especially when you see a younger population. And we do have a little bit of a concern when patients need more and more levodopa to add a dopamine agonist or give other medications. But in older population, the dyskinesia risk is much lower. Dopamine agonists, in contrast, usually have a much higher risk of impulse control issues, especially in male. Although that being said, they usually is more young male. They also have excessive daytime somnolence. They can cause hallucinations. They cause orthostatic hypotension. So although levodopa can also cause some of these side effects, dopamine agonists are much higher. They have much higher likelihood of causing these side effects. So usually in my practice, I usually do not initiate dopamine agonist unless I'm kind of cornered, like I don't have other options. And especially after, and that requires lots of counseling. You have to explain to the patient the side effects because, as I said, sometimes the quality of life is driven by the non-motor symptoms, not so much by the motor symptoms. You may have some motor benefit that if they're having side effects in the non-motor domain, then overall the quality of life goes down rather than improving. So overall, levodopa is the first line of treatment, the preferred drug to give in a patient who is in this age group. And also to ramp it up slowly, and avoiding dopamine agonists would be like a general concept that dopamine agonists are not well tolerated in people who are older. Now, how do you start Mr. A on medication? No, again, this is different and everybody has different ways of doing this. Usually we have two preparation, one the carbidopa levodopa, which immediate release, or the carbidopa benzerazide. So I think we have both the preparation even in India. Usually, specifically if somebody has issues with orthostatic hypotension or has hallucination or has confusion, I really go slow. I would really start with half a tablet increment and go up to 1 tablet TID as a minimum dose to have enough peripheral decarboxylation for the dopamine to have effective thing. I would suggest doing immediate release. Control release has erratic absorption, and thus it's not something that I would start and give it in the daytime. We could add that, especially for bedtime or nighttime symptoms, but not the initiating medication. The usual target is the minimum effective dose achieving satisfactory motor control. And this requires counseling because levodopa does not help everything. It usually helps the stiffness, slowness. For tremors, it's a hit and miss, and there may be a threshold, but does not have a big impact on balance. It doesn't have a big impact on cognition. It actually have negative impact on cognition, the blood pressure. So all these things has to be discussed with the patient so that they understand what we are trying to improve and what will not improve to levodopa. Sometimes the unrealistic expectation of levodopa improving everything can lead to disappointment and also will make it difficult for you to manage these patients. Additionally, it is only symptomatic treatment. It has no long-term benefit on the disease progression, on how the disease will look in 5 to 10 years. So definitely it's very important to set those realistic goals with the patient to understand that this is not going to stop the disease. It's going to make your symptoms better. So and what are the symptoms that will improve with it? So if you expect you take levodopa and your cognitive functions will improve dramatically, that's not going to happen. Usually the side effects, nausea is the most commonest. The benzerazide combination is usually better tolerated in terms of nausea. Orthostatic hypotension, psychosis, especially in the 70 plus group, are definitely something that we want to monitor for. Now, in this patient, that Mr. A that we showed, some of the things that you should have to worry about is the patient already has a drop of blood pressure. So if you never measured the blood pressure in the first visit, you totally may miss this. And so this patient is definitely at risk of a fall. Dopamine agonist and levodopa both can worsen orthostatic hypotension. It's not just dopamine agonist. So you have to be careful to tell the patient, and that's why the slow titration is done. And then also a little bit of counseling about what to do if they start getting those side effects, especially if they're having dizziness standing up. So you tell the patient you used to have slow position change. They can use compression stockings. They used to take more fluids, and the counseling on that. Now, we started this patient on slowly ramping up the medication to 1 tablet TID of the levodopa carbidopa 100 25 milligrams, but we get a follow-up call. So after a month, we follow up on the patient, and the patient has 3 falls in the last 2 weeks. Patient reports, my brain's foggy, I'm feeling dizzy, my vision is blurred. You bring the patient in, you see the patient, his blood pressure is 101/68, his pulse rate is 67, and standing at 1 minute, the blood pressure drops to 72/56, and the pulse rate is 68. So this is one of the, probably it is the effect of the disease and the drug. It's a combination of both. There's things we can modify. So we can't modify the disease, but we definitely can modify the drug. So as I said, adding levodopa can worsen orthostatic hypotension. So you just have to be careful about it. And this could be a very common cause of falls that patients have. And if you don't discuss it, or we do not do the blood pressure orthostatic drop in the clinic, then we miss totally on it. Now, in orthostatic hypotension, Parkinson's disease is a neurogenic orthostatic hypotension. The diagnosis is made by a drop in systolic blood pressure more than 20 or a diastolic blood pressure more than 10 within 3 minutes of standing, but after 1 minute, and there's a lack of compensatory increase in heart rate. Usually when there's a drop in blood pressure, the heart rate should increase at least by more than 15 beats per minute. But if that doesn't happen, then most likely it's a neurogenic, that's probably because of Parkinson's disease. The symptoms can be very varied. So some patients may say they clearly can tell you about like a syncope, like a dizzy feeling. Some people will just come with unexplained falls. So if you don't check this, you think the falls are happening because of off phenomena or because of freezing, then you totally miss on this treatable orthostatic hypotension. Some patients can present with headache. The headache usually has a specific distribution called the coat hanger headache. So it's usually in the neck and around the shoulder area. These patients can have cognitive issues. They can have troubles. They say, some people will say excessive sleepiness. So they have their food, and just after having their food, they feel very, very sleepy and foggy. They usually exist with other dysautonomic symptoms. They usually will have troubles with bladder, constipation, may have perspiration, palpitations. So they may have other autonomic symptoms, and this is kind of a manifestation. And honestly, it's more difficult to, measure those, and blood pressure is an easy thing to measure. So you just have to spend time on that and think about it. Now, as I said, all dopaminergic medications can lead to blood pressure drops. Levodopa, compared to other group of medication, including the dopamine agonist and the MAO-B inhibitors, is less likely to cause it. This patient was on tamsulosin. So the patient was on tamsulosin. It's an alpha blocker. So that again is a possible, the beta blockers, diuretics, and especially in this population, these patients can have cardiac comorbidity. So they may be all these medications. And so it's very important to discuss this. SGLT2 inhibitors, antidepressants can also drop blood pressure. So you have to see the risk benefit analysis of each medication the patient is on, and to see the optimal balance of what is affecting the quality of life of the patient. Now, how to manage orthostatic hypertension? Now, broadly, there are two ways we manage them. One is non-pharmacological, and this is very important. The non-pharmacological, there are studies now to show that the non-pharmacological may be as good as the pharmacological options, and almost, unfortunately, we don't have lots of trials. So what are the non-pharmacological approaches? So using volume expander, so giving fluids, cold water bolus. So as soon as the patient gets up in the morning, the patient takes a big bolus of 250 to 500 ml of cold water, trying to wear a compression binders. I've seen most of the patients don't tolerate the compression stockings just because it's so difficult to wear them. So I think it's easier for them to use a compressor binder. Then teaching them physical counter maneuvers. There is a MDS tip sheet where they have diagrammatically represented how to do those counter pressure maneuvers while getting out of the seat or when they feel the dizzy feeling. Avoiding exposure to heat, alcohol, these things, especially in India when it's so hot, avoiding them to go out when they have that kind of heat. Avoiding big meals, taking small meals at a time. Sucking on ice chips right after a meal can also help with that postprandial stuff. Use of acarbose has been tried to decrease the gastric emptying, so that also will help with the postprandial orthostatic hypertension in that patient. Another important thing is the raising the head of the bed. Actually, there's a randomized trial where they're trying the whole like tilt bed to see how much it has effect on the not only this orthostatic hypertension, but also the supine hypertension that can come with medications. Now, these are the non-pharmacological measures, but there are not very many options for pharmacological options. So the one that we usually try are midodrine. So midodrine is an alpha-1 agonist. You can start with it's a TID dosaging. You start with 2.5 milligram. You can go up to 10 milligram TID. The problem is it can cause supine hypertension. So that kind of a tricky thing to try. People who have supine hypertension, we are not very aggressive with it. We really don't monitor them all the time. But usually for me, I usually tell the patients if they start having supine hypertension, raising the head of the bed can definitely help. The additional thing, if you're really dealing with really high numbers, like going above 200 and systolic, then the things that I usually ask them to do is, one is to put a nitro patch. So when they go to bed, they put a nitro patch, and then it's run with the 2 milligrams, and they take it off in the morning when they get out of the bed. So that can be something that they can use because it's short acting, or you can use a short acting blood pressure medication like clonidine. So those are measures that you can try. Fludrocortin is another medication which you can try. Usually it's contraindicated in patients who have CHF or kidney failure. So you have to be careful with that. Pyridostigmine, there is some evidence. The benefit of pyridostigmine is it doesn't cause supine hypertension, but it does come with other side effects. So it comes with diarrhea, cramps because of the effects on the gut. So there are side effects. Now, in this patient, we saw he was on tamsulosin. So we'll take the tamsulosin off, gradually ramp it down. And then even if after that it doesn't improve, then we probably could consider him starting on midodrine or fludrocortisone based on a discussion with the patient about what works for him and what are the comorbidities the patient has. Of course, we'll have to follow up on this supine hypertension bit by measuring it just once a week or twice a week, but it's not something that has to be done all the time. So overall, if you see for patients who have orthostatic hypertension, the first important thing is medication review. Most of the time, patients are on multiple medications. So this would be a discussion with the patient, what is really required for them. Then we remove the drugs which are causing orthostatic hypertension. Sometimes if the patient's quality of life if this patient is constantly falling, then I sometimes even sacrifice levodopa. You have to cut back on the levodopa if you think that is the culprit, because this could, as I said, it's a combination of the disease progression and the drug, but it's very difficult to dissect out how much is what. And so sometimes you cut back and see if it really improves with that. If it does improve, then you go back on it. If it does improve, then you sometimes have to sacrifice the motor symptoms for improving the orthostatic symptoms. We do the non-pharmacological measures, and then you do a pharmacological measures, and sometimes you have to do a combination of both pharmacological plus non-pharmacological measures. So that's how you the broad guidelines of how you manage orthostatic hypotension. Now, the same patient, now we are moving forward. The patient has 5 years of Parkinson's disease, and so he's now 79 years old. He's taking levodopa, carbidopa, 100-25 milligrams QID. He's taking them every 4 hours. Now, his medication, he's complaining now of having medication not working 45 to 60 minutes before each dose. During that time, he feels that I'm very stiff, I have difficulty walking, I can't do things, I really have to, I avoid doing things at that time. Additionally, he also noticed some involuntary movements of his trunks and arms 60 to 90 minutes post-dose. His MMSE is 24 out of 30. Now, so this is the beginning of something we call as motor complication. I think many of you must know about why we have motor complication. So what happens as the disease progresses, neurodegenerative disorder, so your brain is losing the dopaminergic neurons. In the early disease, the brain production, if you see this figure, the brain dopamine production is constant, correct? You're taking the medication from outside, but your clinical motor response usually is more steady. It doesn't have the peaks and troughs because the brain production is still enough. And the production of because the brain production is good enough, the patient doesn't feel any fluctuations in his motor symptoms. But as the disease progresses, there is loss of the dopaminergic neurons. And thus now, because the brain production is minimal, there is the motor or clinical response now starts getting these peaks and troughs. And that is the reason for motor complication. Now, there's lots of studies which have shown what is the prevalence of, or how many patients develop motor complication. There are studies which have shown 50 to 80%. There's definitely an age-related effect on this. There is a study on a cohort that patients who are older, more than 70 years, are less likely to cause dyskinesia compared to somebody who's younger. So it may range from 50% in somebody who's in the 40 to 59 years to almost 16%. So that's why the likelihood of dyskinesia is less in patients who are in the geriatric population. So that's why like the use of levodopa that's why the first-line treatment and dopamine agonists are not the first-line treatment, especially also because of the adverse profile. Now, in terms of the motor fluctuations themselves, there are different types of motor fluctuations. The common one in this patient that we saw was the wearing half-life. So what was happening? The patient takes the medication. It takes few minutes, like 30 minutes or so to kick in. The drug goes up. The patient has a motor response, but the medication, the effect does not take the patient to the next dose. So there's a gap or there's an off phenomena. So the medication wears off before the next set. Now, there's some other forms of motor fluctuation. One is delayed on. This is dependent on the gastric emptying and the intestinal absorption. The patient takes the medication, but it takes a long time for it to start. So the patient does not have an adequate on, or when the adequate on happens, it happens very late. The effect is mostly because the absorption and the protein interaction and the gut itself slowing down may be the reason for the delayed on. Sometimes patients can have troubles with no on, and that means the patient takes the drug, and of the 4 sets that the patient takes, one of them has no effect. So the patient does not feel any effect. And again, it's a more complicated pathophysiology behind it. It could be because of the erratic absorption, erratic emptying, but also how the blood-brain barrier transportation is happening. It's usually difficult to manage these things. Random on and off, again, the patient's off and on cannot be predicted. I think the most challenging of all the motor fluctuations, random on and off. The mechanisms could be the changes that's happening in the striatum and also the pharmacodynamic changes that comes with the progression of the disease. Now, with wearing off, so usually if there's a reemergence of the symptoms before the next set, and if the patient is having the wearing off, which means the medication's effect takes longer, so it takes some time to come on, and then the patient wears off before the next medication starts. So usually less than 4-hour duration of an adequate dose of levodopa, we call that as a wearing off. Now, what do you do when you have wearing off, especially in an elderly patient? So The most commonest thing, or especially the first step I think we should do in an older patient, is to increase the levodopa dosage. But you want to give increasing the levodopa dosage sometimes may not be tolerated, because this patient also had, he said, around 60 to 90 minutes, he starts getting dyskinesia. So we do usually try more frequent but smaller dosages spread over time. So that ways we can avoid the peak dose dyskinesia that the patient was happening. Additionally, you can add a COMT inhibitors, which basically inhibits the metabolism of dopamine in periphery, or you can add a MAO-B inhibitor like rasagiline, which will prevent the degradation of the dopamine in the brain. So the COMT inhibitors that we usually use are entacapone. I think we don't have tolcapone or opicapone in India, correct? Ila, I don't think so. We have it as yet.
Opicapone is not available currently.
Yeah. So entacapone, one of the important things that you have to worry about entacapone is usually when you give entacapone and MAO-B inhibitors in these patients, there are interaction with medication, especially with the MAO-B. So if the patient is on SSRIs, the patient should be aware of those interactions. I usually, in a patient who is above 70, I would not try dopamine agonists. So this is an algorithm for a general population, but specifically for this group of patients, I would be avoiding. Now, there was a Cochrane review where they analyzed 44 randomized controlled trials, and they saw that the dopamine agonist had the maximum reduction in the off time of 1.54 hours versus MAO-B inhibitors doing 0.93 hours and COMT inhibitors 0.83. So although you get more on time with the dopamine agonist, it is the question of how the patient tolerates it. So as I said, if nothing works, we may try dopamine agonist, but something that has to be discussed with the patient after they understand and has to require close monitoring of what's happening. If the patient does not, the medication does not work, then you can start thinking about devices for continuous administration of levodopa, which means they are like the advanced therapies or device-aided therapies. Now, for key points for geriatric patients, just a summary is levodopa is the first, most effective, safest treatment option. It does have side effects, including effect on the cognition, hallucination, orthostatic hypotension, but much less compared to the other adjuncts. Have to be careful about delayed on or no on. Usually this is because of gastroparesis, but not true wearing off. So we have to manage that part more, especially moving the dietary protein to the evening. It's a simple thing. A patient having more daytime fluctuation, ask the patient to take protein in the evening rather than taking it in the daytime, especially most of the daily activities are done in the morning. Medication to avoid or use with caution, as I said, not avoid, but definitely avoid anticholinergics. Lots of patients in India, we use a lot of anticholinergic in patients, especially for trauma management. So that is important to because they can cause confusion, they can make worsening of all the non-motor symptoms. Dopamine agonists are more likely to cause hallucination, more sleepiness. Amantadine, again, is a medication that you have to be careful. So amantadine usually comes in 100 milligram dose. And it's a capsule in Canada. But we usually have a liquid formulation to give 50 milligrams. So if a patient is very, very sensitive and is more likely to cause confusion, hallucinations, it also can cause skin changes. So something that you have to discuss with the patient. So I have to be a little bit careful with these medications, especially in the elderly group. Now, as the disease progresses, if you see this picture, the green part, in the early disease, the drug is taken in, it peaks, it drops. And you have a good response, smooth response throughout the day. You do not have any dyskinesia. But as the disease progresses, this window goes narrow and narrow, which means you have less on time. And also, when the medication peaks, you start getting involuntary movements, which is a dyskinesia. And this threshold goes down and the efficacy threshold goes up as the disease progresses. This just happens because of the degeneration that's happening in the brain and the sensitivity to the striatal neurons, which makes the patient start getting dyskinesia. Again, less likely to happen in elderly, but still it's a concern. Now, the different kind of dyskinesia that you can see in patients, and this is for all patients, is when the medication is going up, so transitioning from the off to the on phase, you get something called diphasic dyskinesia. It's called diphasic because there are two phases. One is when the transition happens to go up, and when the transition goes down. So these two, and then there's a different kind of dyskinesia when the medication is peak dose. There are some difference in the phenotype of this dyskinesias, which can help us understand what they are, what could be the potential cause. It's very important because the management of diphasic dyskinesia could be very different from a peak dose dyskinesia. So you have to understand what's happening. The thing is, when the patient goes down, people can also have a fixed. So these dyskinesia usually are coriform dyskinesias, and when the patients usually goes down to the off phenomena, then they usually can have a fixed dystonia. So there are different kind of dyskinesias. The peak dose dyskinesia usually affects the trunk. They usually are coriform, and they can have like a one side predominance. Peak dose dyskinesia can sometimes involve the leg, but usually would involve the trunk, the arms, and diphasic usually is more dominantly the legs, not affecting the trunk and the other part of the body. So the phenotype, it's not always correct, but sometimes it can give you a clue. Other thing is to ask the patient to make a motor diary. It's not so easy to do that, so it's kind of a difficult proposition. Now, the off dystonia usually affects your foot and usually causes inversion, curling of the toes. And so all those things can, if looking at the phenotype, you can make a reasonable guess about what kind of dyskinesia is happening. From some videos, and this is from my, so if you see this gentleman, he's having these involuntary chewing movements around him. He doesn't have tardive dyskinesia. He is on levodopa. And so he's having these movements around the mouth. There's another gentleman, if you see, he's having these quite aggressive involuntary coriform movements involving his hemi body. And again, all these are most likely peak dose dyskinesia, correct? So I haven't really done a level testing, but the phenotype is very much like, so there's truncal movement, there is involuntary movements around the face, there is involuntary movements in the hands. So what you do in peak dose dyskinesia is your idea is to blunt the peak. So you want to make it more frequent dosaging. So fractionation of levodopa is what we do in somebody who has a peak dose dyskinesia. Off-period dystonia, again, is usually in the lower extremities. Usually would you see it like a cramping? A video of a lady who does that. So if you see, this lady is due for her next set and she has curling of her toes. She's almost not able to lift her legs. So usually we'll try to, again, increase the levodopa dosage, add adjuncts like Maobi-Comte. Sometimes you use focal dystonia and botulinum toxin injections. It really works well. So many a times it doesn't help because if you increase the dose of the levodopa, patients can have dyskinesia. So it's kind of the therapeutic window goes down. So this is a one place where you can use botulinum toxin injections, especially in the elderly, I think, if they can, if it's really affecting their life. Now, diphasic dyskinesia, I told you, is usually more tricky. So they have the movements right here, like when the disease is like the levels are going up, and then especially when the levels are going. So diphasic dyskinesia, I don't really have a video of it. This is from a neurology journal, which has published the diphasic dyskinesia. So this is a patient who is having these involuntary movements. You can see clearly, and then he gives them the apomorphine dosage. So he's having these coriform movements involving his legs dominantly, not so much. And then he gives himself the apomorphine injection. And 3 minutes, which is pretty rapidly acting medication, is almost back to normal. So this is a diphasic dyskinesia. So looking at the phenotype, if you see a patient who is having lots of gyrating movement of the trunk and the leg, then most likely it's a diphasic dyskinesia. And the management is actually going up on the dose and using other adjuncts rather than going down on the dose. So because it is mostly usually when the drug levels are going up, during that transition, patient gets that. Now, so overall, when you manage dyskinesia, I already told you about it, you usually would add amantadine or clozapine, especially somebody who has peak dose dyskinesia. I want to tell you that amantadine, again, is not very well tolerated. And I practiced for many years in India, and clozapine is something I think we really feared. I hardly used anyone. I think I never gave clozapine to anyone. It was mostly reserved for our psychiatric practice. But clozapine does have anti-dyskinesia effect. It also has good effect on the psychosis component. So we'll talk a little bit about it later. But this is another option, especially when patients have refractory dyskinesias and they are not tolerating amantadine. When you have diphasic dyskinesia, the medication increase can be done, but usually these patients require device-aided therapies, especially if you do even device-aided therapies like subcutaneous apomorphine, or like we have a subcutaneous levodopa infusion, which is available in Canada. You have to be aware that you put the patient on that on a specific dosing, and if the patient is in that transitional dose, then he continuously will start to have the diphasic dyskinesia. So it's important to know what is the mechanism behind it, and how to navigate that. So I've already talked about focal dystonia. Again, as I said, you increase the dose, you give the levodopa in the morning. and then you can do a focal dystonia management like botulinum toxin. Now, the device-assisted therapies, again, this is very basic stuff. When do you start thinking about device-aided therapy? This is a broad rule for anyone who has Parkinson's disease and has having motor fluctuation. It's really not geriatric specific. The rule is 5-2-1. So the patient is taking more than 5 times a day a dopaminergic medication, is taking more than 2 hours of off symptoms, and is having more than 1 hour per day dyskinesia. Then is a patient who should start thinking about device-aided therapies. The device-aided therapies, basically the one is the DBS. I think that's the one that we usually use. I think we have apomorphine pump in India. We don't have it in Canada. What we have here is we have the levodopa-carbidopa subcutaneous pump. We have the levodopa gel, which goes into your intestine. As I said, apomorphine infusion is something that you can use in India, but then deep brain stimulation is another option. Again, in patients who have these motor fluctuation. Deep brain stimulation in above 70 years of age is kind of a, everybody has different perceptions about should we do DBS in patients above 70 years of age. If you go and look at the evidence to back it, there was a systematic review which did show that short term, these patients did have improvement in UPDRS-3. So UPDRS-3 is mostly the motor symptoms, correct? So it checks tremor, rigidity, balance, walking, freezing. It does not check your non-motor symptoms, which is done by UPDRS-2 and 1, correct? So UPDRS-3 does improve. So the motor symptoms improves with DBS, but axial symptoms and the non-motor symptoms do not improve with DBS. So as patients get older, those symptoms drive the quality of life. When you do decision-making about deep brain stimulation, this is something that has to be explained to the patient, because the patient's expectation that everything is going to be fine with DBS is not going to happen. The disease progresses. The deep brain stimulation is not disease modifying. It is symptomatic treatment, and it will only work on the symptoms which are levodopa responsive. So it does have motor benefit, but does not have non-motor symptoms benefit and the progression of the disease, especially in somebody who's older. It's very important to select your patient very, very carefully and not take patients who are, especially the procedure itself, may be poorly tolerated, especially who have comorbidities, and especially somebody who's above 70 years of age. The target selection, somebody who you want to do DBS, so because you have tried everything, you think the patient is great, he's a good target, he doesn't have too many comorbidities, you had a good discussion with the patient. So when the most common targets that we use for deep brain stimulation is STN and GPI. GPI is definitely better tolerated than STN DBS. Only difference being is especially if the patient has cognition and hallucinations. So I would probably choose GPI over STN. Additionally, I also would do a phased deep brain stimulation, which means we'll put a lead in only one side, see how the patient tolerates, and try to do the second side just to avoid complications of the surgery itself, especially the intraoperative. And when the lead implantation happens, the possible cognitive issues that can come with DBS. So you should do a phased deep brain stimulation surgery rather than doing it one go bilateral. So as I said, in my own practice, I really am not very keen on, I give the option to the patient. I tell them the pros and cons, and usually they choose. But everybody is different. So like the choice should be on the patient sides after they have an informed discussion about what benefits and side effects and the procedural risk of each procedure is. Now, let us go to the next thing. It is same patient starts getting visual hallucinations and really becomes very, very disturbing. He starts having visions. He's seeing people who are trying to attack him. He starts running. He falls and has a hospital admission. At this point, the patient is on rasagiline. He's also on Stalevo. So Stalevo is basically a combination of levodopa and entacapone. So it's a COMT inhibitor, and the patient's taking 3 times a day. He's also on pramipexole. His MoCA score has gone down. It's become 17 out of 30. Now, when you have a patient who is in psychosis on multiple medications, including dopamine agonists and other medication, even before you start thinking about changing the medication, the dopaminergic medication, you have to check the medical causes. Most of the time, patients usually have a medical problem aggravating the hallucination and the confusion. Commonest is UTI. They could be aspirating because of the swallowing difficulty. Sometimes this urinary retention can lead to confusion. It's pretty common. Constipation, like this is something that I never thought of, but we see lots of patients here who come in delirium just because they're constipated. So it is a common thing that you can see presenting as delirium in the emergency room. Fall can lead to subdural hematomas, dehydration, all these things can produce. So the first thing is to rule out a medical cause, and has to be done really properly. Then the next is to now do a review of medication. So you want to stop any anticholinergic if somebody is getting hallucination, confusion. If the patient is on amantadine, you don't want to taper that down because that causes hallucination. You taper down agonist. This next you taper down is rasagiline. So this is like the flow of what we usually do. We try to stop the anticholinergics, followed by amantadine, then the dopamine agonist, then the rasagiline, then the entacapone, and the last is the levodopa. So if the patient is not improving and the hallucinations are continuing, we sometimes, as I said, sacrifice the levodopa to maintain the cognitive and the coherence of the patient. So even at the risk of motor worsening. Now, we also assess for PD dementia, so do screening tests for that. And most of the patients with Parkinson's disease by 8 years of disease will start developing dementia. And use of antipsychotics has to be discussed at this point of time, and we'll talk a little bit about that in the future. We want to avoid any antipsychotics which have dopaminergic blockade, like haloperidol, olanzapine, and risperidone. The common ones that we use is quetiapine, but I'll talk a little bit about it because it's not really evidence-backed. So if you have a patient who has PD psychosis, as I said, the first thing is you have to think about any triggers. It could be a infection, it could be metabolic abnormality, it could be environmental trigger. Like if I had a patient who was fine, she went for a Europe tour, there was a change in the time zone. She lands in Paris and she's fully confused just because she had a rapid change in her time zone, a rapid change in her environmental thing. So this is something that you have to tell the patient that if you're traveling, take it easy, understand what's going to happen when you move, go to a familiar place, take your time to get acclimatized to it, because change in environment can just make sometimes that may be just the only trigger for confusion. Of course, you want to change the medications. And then you are then trying to do, if the non-pharmacological measures are not working, then the three options. This is American practical neurology guideline. So they have pimavanserin. We do not have pimavanserin in Canada. So our options are actually clozapine and rivastigmine. Now, clozapine, whenever you give clozapine, you have to do a QT test, but also you have to also check for metabolic issues. It can lead to weight gain. It can cause diabetes. It also, the biggest thing that really scared us was the decrease, the agranulocytosis and the effect on the neutrophil count. So it's very, very important to understand what the side effects are. Rivastigmine, again, can cause worsening of motor symptoms, especially tremor can get worse with rivastigmine. But in some patients, it may have a mild benefit with the psychosis symptoms that the patient has. Now, I'm going to talk a little bit of clozapine, especially because like my experience of not using clozapine ever in India is, I think, driven by the scare of clozapine causing lots of psychosis. Honestly, I think we were worried that we'll not be able to follow these patients. Now, there's lots of evidence. There are actually at least 3 randomized trials, 13 RCTs, and a meta-analysis that has on 1142 patients, where the only drugs which had efficacy was clozapine and pimavanserin. We don't have pimavanserin. I think we don't have pimavanserin in India too. So I think clozapine is a very, very underused drug, and which is not all over the world, not just in India, here too. Like we're worried about the granulocytosis component, the neutrophil component, especially how to monitor those. So, but those are the ones which have the highest efficacy. Quetiapine has been tried, but only has no benefit on the psychosis itself. It can just make the symptoms like hallucinations better, but overall, the effect on the efficacy on the psychosis component on a study was insufficient. It was not efficacious agent for management of psychosis in somebody, especially a refractory psychosis. So they both have very robust evidence. The clozapine dosing. So the literature for the clozapines agranulocytosis is from the psychiatry world. So the doses that they use in the psychiatry world is usually they go up to 300 milligrams. Whereas in Parkinson's world, they actually is a very old study. This is probably in 1997, where they found that the response for psychosis came at 10.6 milligram, which is kind of much, much lower. So if you really do the calculation, the risk of agranulocytosis and neutrophilia, neutropenic decrease in neutrophil count is 0.8 to 1% in the psychiatry. Like most of the studies are from the psychiatry world. But probably in the Parkinson's disease world, the risk of clozapine causing the granulocytosis is around 0.1%. So it's a pretty low risk. It doesn't have any motor worsening, motor symptoms. It does actually have an anti-dyskinetic effect. It also improves your sleeps and also prevents long-term recurrence of psychosis. So it is actually a drug that should be used more. I think we have to figure out, so there is a very strict protocol of how to monitor the clozapine in the US and even in here. So as I said, we have to figure out a way how you can use it, but also have a rigorous or robust way to monitor if somebody gets side effects. Because we used to use a lot of azathioprine, okay, methotrexate, like right here and right there. Not worried about it, but I think we had this scare about clozapine causing something which will be totally irreversible, and we didn't use so I think this is kind of underused and requires more discussions of how to monitor it and how to use it more in our patients with Parkinson's psychosis, especially for somebody who has dyskinesia. Okay, so this patient, what will you do? So you'd cut the rasagiline, you'd cut the Stalevo, you gradually take the patient from pramipexole. You will switch the Stalevo to a Cinemet CR. That's a simple because entacapone also causes worsening of psychosis. You will add quetiapine. If the quetiapine doesn't work, then you go to clozapine. You can also try the rivastigmine if the patient has evidence of dementia as a PDT. Now, for dementia, the drug that has evidence, the only drug that has evidence is rivastigmine. Donepezil doesn't have evidence. There was improvement. So the rivastigmine is available in two forms. You can take it by orally, or you can use a patch. And there's evidence to back that it did in a placebo-controlled trial. It did improve the ADAS-Cog score. It does make worsening of some of the motor symptoms, especially the tremor. So usually, ideally, rivastigmine should be tried, and donepezil can be tried. In clinical practice, I think people use more donepezil than rivastigmine. But as I said, the evidence is more for rivastigmine. And really, we don't have too many options, and we don't have too many things to try in somebody who has PD dementia. The main thing and the last, I think, very, very important part of management of Parkinson's disease in young or in the older people, especially in the older people, is the concept of multidisciplinary care. I think that is something that we have to figure out how to do that. So this is a very elegant article that has been was published in Lancet by Dr. Bastian Bloem and Dr. Kuhn. If you see the person with Parkinson's disease is at the center, and usually who manages them. So in India, it's usually the neurologist, okay, or the MD physician who sees the patient. So usually these are the two people who see these patients. But these patients have involvement of multiple systems, not only the brain. They have gut issues, they have constipation, they have swallowing troubles, they have bladder issues, they have depression, they have psychosis. So they have so many symptoms. So there's a significant important role of having allied health personnel also contributing to the care of these people. Occasionally, they may also need opinion from like a whole range of other other specialists. Again, they're not very much involved, but definitely the two circles, the center one and the second one, are an important part of managing somebody who has Parkinson's disease, especially in the elderly people, because like the non-motor symptoms really become more prominent. The pharmacological treatment for non-motor symptoms are limited. We don't have not many options. The other thing that I really think is important is the concept of self-management. That's a big problem because these patients live with Parkinson's disease. They will die with Parkinson's disease. So they have to be able to manage their disease or manage their symptoms, which comes with their own information and their caregivers' knowledge about how to manage their symptoms. Of course, there'll be support from the pharmacotherapy. There'll be support from the allied healthcare personnel as much as we can. And of course, a higher therapy. But I think it's a combination of all pillars. You have to have all things. And I think usually patients, especially patients want us to fix everything. But I think this would be a discussion about, this disease is a chronic disease. It will change over time. Your symptoms will change. Your problems will change. And so information about symptoms and how to manage them is very, very important in managing something like Parkinson's disease, which changes very much over years. It changes totally different, like the phenotype is totally different. So we did a care model study, which actually is not published, but basically a care model which was driven by a nurse. And this was done during my fellowship. So it was called the Eye Care PD Consortium. So we used a care model which was driven by a nurse and was tried in 6 countries, 1 in Canada and 5 European countries. They had different systems, correct? So these were not exactly a copy of how Canada works. So it was different, but what we tried to see is it feasible to use the same principles? And the principle of this care model was self-management, and it was led by the nurse, not a neurologist, not a woman disorder neurologist. So the nurse, who had a Parkinson's nurse, was the lead, and she was the one who was creating the care model for the patient. And then we saw that it did have some early trends of efficacy. The trial wasn't designed to test efficacy, but it was feasible, and the same principle were used in 6 countries and did show some efficacy. Now, I think it's very, very important for people who live in a country like India. So it's very different healthcare system from a Western country. Patients have access to doctors very quickly, correct? So you can see 10 doctors in a month if you have the ability to do so. But I think what we need is a care model which is for Indian, the kind of healthcare that we have. So I think it's very, very important to start developing or at least brainstorming ideas and try to see if there is feasibility of doing a care model study. Because as I said, this disease, the proportion of people who have Parkinson's disease is going to go higher and higher as our population increases and as the aging population increases. And definitely there should be lots of efforts to start working on models to manage not just the medical, not the whole multi-system affliction of the Parkinson's disease. Okay, so the final message. So in patients in managing Parkinson's disease in geriatric patients is not about just treating a movement disorder. It's managing a complex multi-system disease in a vulnerable individual. Levodopa is the most effective and safest therapy, but requires anticipating complications, simplifying regimens, and addressing the whole patient through a multidisciplinary care, not just the motor symptoms. Thank you. I can take any questions if there are any.
Thank you. Thank you, ma'am, for that comprehensive and holistic overview of this slightly complex topic, because there is not much evidence of how to choose and what to choose. And often at times, a lot of clinician experience and expertise plays an important role. So thank you for sharing your experience with us. So we do have quite a few questions with us.
Okay, can I stop sharing?
One of the delegates want to see the slide with pharmacological agents used in Parkinson's disease.
Okay, I can share my slide set. That's okay. I have no problem sharing the slide set. So I can give you the PDF without the videos, and you can share it with the attendees.
Asmita, maybe you can collect it from ma'am and share it with all the attendees. Then we also have Chandan Mishra wanted to ask about pimavanserin. So I think Dr. Deepa has not much experience with pimavanserin. We do have it in India, and I would say it is moderate efficacy, but it is FDA approved, so it features in various guidelines, and it is often used, at least in the US, as compared to other medications. And there are 2 other questions. Dr. Manjari wants to know about sleep issues in older onset PD.
Yeah, so the sleep issues are, it's a whole seminars, not, so Dr. Manjari is a sleep specialist. So what we do usually is the problems that you can have in sleep could be like maintenance of sleep itself, initiating sleep, maintenance of sleep. So you have to figure out what is the cause for it. So sometimes it could be a motor symptom, correct? So patient is having difficulty turning in the bed. So sometimes the sleep issues are because of the motor symptoms. So if the patient is having nighttime akinesia and cannot move in the bed, so their sleep may be affected. So in those patients, you may have to give them a slow release levodopa preparation. If the patient is good and you are comfortable using a dopamine agonist, like we don't have the rotigotine patch in India, correct? I forgot about it. Yeah. So we have the rotigotine patch here, but you can use like a slow, sustained, like a extended release dopamine agonist, which can help with the nighttime sleep. If things don't go well, then of course, device-aided therapies can be used mostly for the motor symptoms. Now, the other thing it could be driven by the anxiety, the mental health issues that the patients have, like the anxiety, or depression, which can have a significant impact on sleep. So we're trying to manage those, and giving medication for that can help. Patients can also have things like REM behavior disorder, if patients who have Parkinson's disease, and that usually it's not very disruptive. I would give the REM behavior disorder patients mostly, there's a risk of fall from the bed, hurting the partner. So trying to give like melatonin. If the melatonin doesn't work, I usually avoid benzos in somebody who's above 70 years of age. So look, so definitely there are lots of things that happen in the sleep, and sleep can be a major contributor, especially like as it's sometimes very difficult to understand, is it motor or the non-motor aspects that are causing the and bladder is a big concern. Patients who have increased frequency and urgency and autonomic dysfunction happening, bladder becomes a major issue. So patient can't sleep because they're getting up every hour to go and go to the bathroom and pass urine. So it's definitely a big like there are lots of issues which requires like a tailored history examination, and then try to figure out what's the cause for that.
And Dr. Sita Lakshmi has two questions. One, I think ma'am has already answered preferred treatment for RBD. So to just reiterate, the first time preferred treatment, especially in the elderly people, is melatonin as compared to something like clonazepam, which can be equally effective, but the cognitive and other issues are more likely with benzodiazepine. And what about depression in the elderly, ma'am?
Yeah, the evidence is not very robust there, correct? So it's this, as I said, the pharmacological agent. So actually, there should be a randomized controlled trial that you can do in AIMS or like in any tertiary care center. There is no one medication or the other. The common ones that we use for depression is it'd be like a SSRI, metazapine. But as I said, there's no head-to-head trial to compare and say, okay, one is better than the other. Again, how the patient tolerates, what are the side effects, especially if somebody is on rasagiline. You cannot give this SSRIs because there's a possibility of a serotonin syndrome. So there are other things, but as I said, the evidence is not very robust. So it's a good time to do a clinical trial on that.
And we have one very controversial question. We recommend deep brain stimulation in troublesome dyskinesia in elderly above 80.
Yes, so if you have only troublesome dyskinesia, I would still consider GPI DBS. It is definitely controversial. The patient has to be very much counseled about, and I will do a phased, like one unilateral, just one-sided GPI after counseling the patient, having a detailed neuropsychological assessment, having detailed psychiatric assessment, everything. And then because GPI works very well for dyskinesias, correct? So GPI is a bigger target, better tolerated for cognitive stuff. So I know I haven't done it, honestly. I usually, as I said, we have more options now. So patients are choosing non-invasive options, like especially we have the subcutaneous levodopa, which is kind of a pump. So you just put it, it's non-invasive. So patients are less and less choosing DBS, especially somebody who's like 80 years old. But there is evidence from other centers who have done it. And as I said, if you're really worried about it, I would probably do a phase. So you just do one side and then see how the patient does, because the side effect profile would be better, much better than if you do both sides, and then try to do the other side. And like you really have to be have a detailed discussion with the patient about the potential side effects, mostly the cognitive side effects of the procedure itself, like how will the brain tolerate a lead getting implanted into the brain.
And I think Dr. Nabil has a question on the use of focused ultrasound in Parkinson's disease. Dr. Deepa does have access to focused ultrasound, but does she really prefer it over DBS?
No, not really. I have never sent a patient who has Parkinson's disease to. So we have focused ultrasound. I usually use it for essential tremor. I know it's really in vogue now. It's pretty good for somebody who has tremor. Like it's a good treatment for tremor, correct? But it's not reversible, correct? You're making a lesion in the brain. You're not making a hole in the skull, but you're making a hole in the brain, correct? So it is invasive. It's non-reversible. Again, as I said, I have never personally sent a patient for focus ultrasound. Honestly, if I have a patient who has really refractory tremor, Parkinson's disease patient, I would discuss. And if you think the patient is not okay for a STN or a GPI, I would probably do a unilateral VIM. So I would like a VIM DBS. But because the reversibility component is there in that. So this is this thing, and honestly, I don't think there's a head-to-head trial to say focus ultrasound versus DBS to say what's more efficacious. But PD is a progressive disease, correct? Unlike essential tremor, where the progression doesn't happen very quickly. And again, the focus ultrasound has come in the last few years, correct? It's not been for years. Like I have, like in the long term, will those patients' tremors come back? The first thing is that. Second, I have seen patients who had WIM DBS for tremor. When the tremor goes away, they start getting other symptoms. So they start looking at the bradykinesia because the tremor was masking the bradykinesia. So they're not happy because they now see, oh, I couldn't do things because of the tremor, but now I still can't do things because I have bradykinetic, correct? So I rather do a STN or a GPI DBS in somebody who's younger and a GPI in an older patient rather than do like a focus ultrasound because it's not a static disease. The disease is going to go progressively go down. And I want to have more, tools to manage the bradykinesia, the stiffness, the rigidity, if I ever do it in a person who's that old.
So I would like to add something to this. So at least in the Indian population, we generally offer device-aided therapy quite later in the course of disease. It is not common practice to do some procedure or deep brain stimulation or apomorphine pump therapy early in the course of the disease. And Parkinson's, by and large, though it is asymmetric, most of the times in the later stages, it is already a bilateral disease. And focused ultrasound, as on date, the FDA does not recommend bilateral lesioning at the same setting. And so it may not be really a very good choice for just for Parkinson's disease, at least as on date with the current level of practice that we are doing. But maybe over time we may have more experience, because when I was working in a center in Spain, there is a trial that is ongoing in which patients with very early Parkinson's disease with unilateral tremors, in whom they are fairly convinced that it is Parkinson's disease, even before starting levocarb, there is a tendency to do a lesioning procedure so that they are pill free for a very, very long time. So that sort of practice is not actually very common in the Indian setting, and maybe it is not relevant to discuss very, very hypothetical scenarios. So probably no. And Dr. Soumya has a question. In a busy neurology clinic, are there any scales? Do you use any scales to assess levodopa-induced dyskinesias to quantify and follow up, modify the medications?
Like if you say MDS4 is the one that you should use, it's not a very big scale. Like if you just want to see the motor fluctuation part, if you want to do just MDS4, it's not a big scale, correct? MDS3 and 4 are what I like. 3 is a little bit longer, like, but as I said, because I'm a movement disorder neurologist, I have the liberty of getting 30 minutes to see a follow-up patient, which is very unlike what I used to do in AIMS. So it's different. So I usually do MDS here, especially because I work like a movement disorder specialist. So, but as I said, if you don't have the time to do like the full MDS3, then you can at least do the MDS4, which is not like only few points. So it will tell you, see, like the percentage of time off, kind of dyskinesia, of dystonia, like it's not very long. So you can probably do the MDS4, only the MDS4 for managing motor fluctuations.
I would like to add,
I think there's one good idea. I think with everybody now using phone, you can actually send the MDS1 and 2 before the patient
Yeah.
comes to your clinic.
Yeah.
And then it can fill and you can see, and that's something that you can actually do before even seeing the patient. So that's a very good idea, because you can send the patient, like you can send your secretary or whoever to send those MDS1 and 2, and the 2 especially is a patient fills questionnaire. So the 2 gives us lots of information. It involves all the non-motor symptoms, because if you only do MDS3, then you miss out on the non-motor symptoms. And if you don't have a busy clinic, definitely it's a good idea to have either that sheet on your phone or your laptop, and you see, okay, the patient is okay, 0, 0, 0, like he's good on these scores. Or if you have a specific thing that's not doing well, you can have a discussion on that. So you can make it. I know it's not easy, and I never did it in India, honestly. Like I really didn't have time to do it, but I think now there are ways we can use technology to make that easier.
It is quite common in various centers in North America, where when the patient is in the waiting hall, they just make the patient fill these scores on ICD, dyskinesias. But Dr. Soumya, what I would like to say is, in the clinic, the scale may not be very relevant. Dyskinesias are not very bothersome to the patients, and I think what will help you tailor drug modifications is how troublesome the dyskinesia is to the patient, rather than looking at a number in a range of whatever. So Chandan's question has already been answered, and Dr. Manjari is very appreciative of the talk. Of course, we know that, and many other people have appreciated. That's nice to know. And one is asking how to approach a patient with Parkinson's disease for more than 20 years. He was totally hyper rigid, not moving, going recurrent aspirations on 4 times a day, pimavanserin, pramipexole, but no change clinically. What to do?
Yeah, so he's on the Syndopa 110. So that's 400 milligrams of levodopa.
Yeah, yeah.
Yeah, I would probably start like he's on pimavanserin. That means he is also having hallucination and confusion, correct? I think that must be the background. That's why the patient is pimavanserin. I would probably cut back the pramipexole first thing because the pramipexole is probably contributing to the hallucination and confusion. That's the first step I would do. Then I'm going to try to increase the levodopa based because the levodopa is the most effective drug. So this is not the maximum dose that you can go up. So you can definitely go up on the Syndopa, correct? So you are only on 110 4 times a day. So that is not enough. I think you slowly increase it. And as I said, you have to go slow. I am very, very slow when somebody who has confusion hallucination. I just take half a tablet every 5 days, increase that much, like 50 milligram every 5 days. And you go up and go up as high, like as much the patient tolerates. And there'll be a threshold of when he starts getting confusion hallucination. So you will have to stop. But I think that would be the most important thing. Now, this patient is having recurrent aspiration. So this is kind of a tricky thing. This does not work. Like levodopa doesn't work on the esophageal muscle. So I think that's very important. If the patient is having aspiration, maybe that's the chest infection happening and causing confusion hallucination. There's a medical problem causing worsening of it. So we have to treat that. So and as I said, we didn't have the resources to do swallowing assessment, swallowing persons as SLP, a speech language pathologist, checking our patients how safe it is for them to have food. But there are, I think one of the best sites that I found is the Stanford's Parkinson's Community Outreach. It has a whole section, and this is a very good site. It has a collation of every possible, not every, but lots of resources for patients, how to eat, how to drink, how to avoid aspiration. People aspirate because they don't follow the things that we can do. Like we never discuss about using a metered cup to have your liquids to avoid aspiration, or using a thickener to have your liquids. Lots of things that we can do to prevent those aspirations. Maybe the aspiration is making the patient confused and hallucinate. So if you manage the aspiration part, maybe he will improve. And as I said, for the motor part, you can increase the levodopa. I think that would be a simple thing. I don't think this patient requires any device-aided therapy. He's pretty good. Like he's probably not eligible for a device-aided therapy. If he's so confused and having hallucinations.
We have a question from Carlos. I think it is in Spanish. I try to translate it to ChatGPT. ChatGPT tells you to answer if an elderly patient can be given an additional nighttime dose of levodopa if needed.
Yes, of course, you can give them, and immediate release really works. The only thing is if the patient is having confusion, orthostatic hypotension, things like that, you have to, this is a common practice, correct? Like to give a levodopa when the patient usually get up to go to the bathroom, correct? So I tell them, do not time it. Don't put an alarm to get up to take it. So when you get up, you take your immediate release, because the slow release is not, the levodopa, the equivalence is not equal to immediate release, correct? So it sometimes doesn't work. Second, it's erratic absorption, correct? It has a sustained release, like a coating on it. So it sometimes doesn't work at all. So immediate release is definitely more effective. The only thing is how long does it take for the medication to kick in, correct? But again, the problem with nighttime immediate release is the confusion, hallucination, those things. And so if the patient is not having those, then I think it's like patients can take a small amount comfortably, no problems with that.
Ashu has a question on treatment of akinetic rigid syndrome. So as Dr. Deepa told, in elderly patients, levocarb is the preferred medication for treatment of all motor symptoms of Parkinson's disease. And she has kindly agreed to share the slide set. So you can go through the slide on pharmacological management. And management of aspiration, we have already discussed. Involvement of a speech and language pathologist would be a good addition. Often at times in institutes, there are certain speech and language pathologists associated with the ENT department. Maybe you can take help of them, but by and large, they are a difficult breed to find in India. Triaxiphenidil. Nabil wants to ask, triaxiphenidil is used commonly in India for tremors. Is there a non-cholinergic alternative?
Yeah, so like as I said, trioxyphenol is commonly used for tremors, but there are studies, and I actually published a study. Usually, tremors becomes less and less as the patient gets older. The phenotype changes. So people who have tremor dominant Parkinson's become akinetic rigid later. So usually tremor, and we don't have to be aggressive with tremor management. I think that's something that we have to talk. Ask the patient, is the tremor bugging them at all? If the tremor is not even bothering them, you don't want to give them trioxyphenidil to make them confuse and hallucinate and not be able to manage their medication, and then they're like off the chart. So that it's very important to discuss how much is the tremor bothering them. If the tremor is usually it's a resting tremor, it does affect people, correct? So levodopa should work for them. As if it doesn't work, you can try it. Like dopamine agonist has some evidence. There's not lots of evidence for Parkinsonian tremor. If it's really refractory, like as I said, there are very few people. I start thinking about DBS stuff because people may have levodopa non-responsive tremor and still can improve with DBS. So DBS is the most effective therapy in people who have
And
tremors.
there is a follow-up question as well. Would you consider propranolol for treating PD tremors?
Yes, I do. So if the patient has, so one is the patient has a resting tremor, I would probably not give propranolol, but most of these patients, I would try if the patient doesn't have orthostatic hypotension to see if it helps because there's this action tremor. So there's sometimes a re-emergent tremor, but sometimes it's actually action tremor. And sometimes anxiety drives it. So propranolol can just take that anxiety off, like take that edge off and make the tremors better. I would try it. I'm not going to keep the patient on propranolol if it doesn't help. I'll take it off if it doesn't help. So it just could be a trial and see how if it helps. And if it doesn't help, I'll take it off, especially because it'll drop your blood pressure. If the patient is already on a beta blocker, especially when I see patients here, almost everybody's on bisoprolol or metoprolol because they've had heart issue, they have AFib, they have something else. So I'd ask change that to a propranolol so that I'm not adding a medication, but I'm substituting a medication with another one so that they can have benefit of both. As I said, I would not continue it if it does not work. Like just because, and if I'm adding it, especially if I would not continue. If the patient is already on beta blocker for some other reason, then it's okay.
Dr. Srinivas wants to know after how many weeks should DBS programming be done after DBS? So
yeah, so here we do it. So ideally, it should be done. So when you do the deep brain stimulation, you have lesional effects. So that means the surgery, the lead implantation makes the symptoms better. So if you have a tremor, the tremor will go away. If you do your first screening before the lesional effect is gone, then you are not doing a proper screening anymore because there's a confounding factor of the lesional effect of surgery. And so you may not get the right threshold of adverse effect and the right threshold for benefit. So I usually do it after like a month here. I know may not be possible. Like if somebody's coming from somebody's coming from Bihar to get it done, he may not be able to come back or cannot stay for a month. So as I said, it's like that's what we do mostly because of the possible lesional effect. So I say like we have to figure out a way how to do it, but not, have difficulty with the lesional stuff. So that's how we do it here. And I think that is probably the best way. But like sometimes we don't have that liberty of having the patient come back after a month or after 1.5 months. Is from the local area, of course he can come back. But if he's coming from a far off distance, he doesn't want to come back, doesn't want to spend the money, then of course sometimes we will have to do it earlier. I know many people, many colleagues in India, my colleagues do it earlier, like when the patient is admitted after a week or so. But that's kind of the logistics. And of course, you have to adapt to that. You can't be very rigid with that.
yeah, there's a lot of institutional variations, and in most places in North America, it is usually done 4 to 6 weeks. In Europe, it is slightly a different way of how they do things. Basically, post-operatively on the second or third post-operative day, they start stimulation based on whatever microelectrode recording, whatever the best target they felt. And of course, they don't do the monopolar review at that time. So they call the patients like 6 weeks later to do the monopolar review. So of course, we can discuss and debate on what is the best way of doing things. And of course, you need to also tailor to your local practice and how your patient wants to look at it. Like, for example, if there is not a big lesional effect, preoperatively, the patient did not have great control, right? So postoperatively, if you are not able to start programming immediately, then maybe the patient is going to have a suboptimal quality of life in the ensuing months. So to be very honest, after finishing my fellowship, I started doing programming only after 4 weeks. And recently, I had a patient in whom there were significant dyskinesias post-operatively, even with half a dose of levocarb, that I had to start the DBS and cut down on the medications quite a bit, even to get him to an on state. So that sort of fine tuning also you have to do, and I don't think it is going to be a one size fits all approach. And maximum dose of levodopa per day in a hallucinations patient. So I think we have discussed this before. It is like a art of fine balancing that you need to balance between hallucinations and motor symptoms. Tremor predominant, we have discussed this. Following, we have discussed. Dr. Sunil wants to know how you manage speech issues.
Yeah, so speech issues, again, as I said, you should go to the Stanford site. So the effective speech therapy that works for patients with Parkinson's disease is the LSVT, or the Lee Silverman technique. And that's honestly, here, even here, we have very few speech therapists who have the techniques. It's pretty pricey here. It's not covered. So patients who have speech, they only get coverage for like couple weeks, and then they're done. So they don't get long-term coverage. There is an online LSVT, like it can be purchased, like a CD of a speech person telling you what to do. There is an app called Loud and Clear. So basically, this is almost like physiotherapy, correct? But you're doing a speech physiotherapy. This is something you have to tell the patient. It's like a pill. If you don't do it, the effect doesn't last. So you have to do it every day to maintain the benefit, correct? So physiotherapy, speech therapy, all these things have to be done. It is almost like a pill. I really spend a lot of time telling my patients to do that. And as I said, the Stanford site it has lots of videos how to do LSVT. There is an app called Loud and Clear, which is like an iPad or a phone app where you can practice your Parkinson's, like a voice speech therapy. It is not LSVT, but it's something better than nothing. So that's something that you can try. The best possible thing is somebody who's a speech therapist who has I think we have lots of speech therapists in India. So I think that would, like, Canada is a publicly funded society, so the wait time to see a speech therapist is very long. But I think we'll have much more speech therapists in India. So if you have access to that and somebody has learned the LSVT technique, I think that would be the best approach. But if the patient can't afford it, or the patient doesn't have the access, he lives in a rural area, then there are lots of apps. And I think all of our patients have phones, so they can use those things.
Thank you, ma'am, for that interactive session. We'll ask question one more. Non-motor symptom, what to do for pain?
Yeah, so pain in Parkinson's, this could be, there's a questionnaire for pain. Honestly, I never fill it out. It's more for research stuff. I don't have time to fill out all the questionnaires. I usually do MDS, UPDRS3. I recently started giving the patients MDRS U2 just to fill out when they're sitting, but we don't have the questionnaire. So pain usually depends upon what the cause of pain is. If the patient is having a foot dystonia and off dystonia causing the pain, then you'll manage it differently from somebody who has pain because of other reasons, correct? So the cause of pain has to be figured out before you try. I do not give lots of medication for pain, correct? Like I don't give, unlike India, here they give lots of morphine. And those are patients who have pain, they get already on lots of hydromorphone. So kind of I don't really give a pain medication. Sometimes you can use duloxetine, which is antidepressant, and also a pain medication if they have other reasons for pain. But as I said, it has to be specifically what is the cause for pain that is important. So sometimes pain could be because of neuropathy. The patient has diabetes, correct? So it's a different management from somebody who has a foot dystonia and a pain because of the dystonia. So it'll be a very different management. You have to figure out why he has the pain or why she has the pain, and then try to solve that.
Thank you, ma'am, for that wonderful session, and for taking out time from your busy schedule, and all the participants from. I see people from all over the world, and especially in India, it is quite late over here, and I still find it very heartening to see that we have an enthusiastic audience who are very interactive and have made the session actually much better as compared to something which is going to be a didactic lecture. Thank you. And thanks to
thank you.
Asmita and the entire IAN digital team also. Thank you.
Yeah, thank you. Thank you, Ila, for inviting, and thank you everyone for listening to me. Good night.
Thank you. Bye-bye.